Hi, everyone. I'm Guilherme Fenelon from São Paulo, Brazil. It's a pleasure for me to be here to talk to you about in this LAHRS Congress about cognitive decline in atrial fibrillation. I'd like first to thank the organizing committee for inviting me to participate in this very important Congress. So these are my disclosures. It's well recognized that atrial fibrillation is independently associated with several types of dementia, including senile, vascular, and Alzheimer's as well. And this pathology also increases the mortality of patients of atrial fibrillation. So this is a very important issue that has to be tackled by cardiologists. And why is that? First, atrial fibrillation and dementia, they share several risk factors, including age, hypertension, diabetes, dyslipidemia, obesity, etc. In addition, uh, direct effects of atrial fibrillation also occur, including emboli, both stroke and silent infarcts. And also there is a state of low cardiac output with hyperperfusion that may also contribute to cognitive impairment. In addition, there are some pro-inflammatory and pro-thrombotic status that may contribute to brain damage and cognitive decline. And another topic that's very important to take into account is that cognitive decline and dementia in patients with atrial fibrillation occur not only in patients who have had a stroke or TIA, but also in patients that do not have any kind of previous history of embolic events. So this is very important notion that has to be taken into account while taking care of these patients in the clinical setting. And this phenomenon may be related to the high prevalence of silent brain lesions in patients with atrial fibrillation, which is very well illustrated in this recently published study in JACC, which studied a multi-center study in Switzerland studying almost 2,000 patients with a mean age of 73 years of age. And I'd like to draw your attention to the fact that 90% of these patients were on oral anticoagulation, half of them with DOACs and the other half with warfarin. And what we see here in this population is that only 20% of the patients they had clinical stroke and TIA, which is the tip of the iceberg. 80% of this population had silent lesions, silent brain lesions, including microbleeds, white matter lesions, but by far the most important, most relevant lesions were silent infarcts. And why is that? Because large non-cortical or cortical infarcts volume was the strongest predictor of a reduced cognitive function. So the presence of silent infarcts may be related to cognitive decline in these patients. And this is very important, is a very important finding, raising the question whether or not MRI should be done routinely in patients with atrial fibrillation in order to try to detect and eventually prevent cognitive decline. So, if silent infarcts may play a role in cognitive decline, the question is whether or not anticoagulation may prevent this cognitive impairment. And we don't have this answer yet. There are some small studies which evaluated warfarin as compared to aspirin in terms of prevention of cognitive decline, and there was no significant difference between the two drugs. And the conclusion of this paper, which was published in 2014, was that the principal indication of anticoagulation of older paper IF remains the stroke prevention. On the other hand, we know that the time outside the therapeutic range, the TTR, in atrial fibrillation in patients using warfarin is associated with the long-term risk of dementia. Either patients who were poorly anticoagulation with low TTRs, but not only patients with low TTR, but patients with very high INRs, very much over anticoagulated, they also have microbleeds. And patients poorly anticoagulation with low INRs, they tend to have more silent infarcts, and raising the question that appropriate coagulation is key. So whenever you want to coagulate patient, you have to make sure that the patient is adequate, is within an adequate range in order to prevent cognitive decline. So the question that goes after that is whether or not the new anticoagulants, as compared to warfarin, given the more stable anticoagulation levels that we achieve with these drugs, whether or not they yield a better improvement in terms of cognitive function. And what we see, there's a small studies published in 2000, roughly 4 years ago, comparing with this relatively small population, DOACs, mostly rivaroxaban, as compared to warfarin. And what they show is that DOACs seems to be better than warfarin in terms of the incidence of dementia. However, this is a small study. There are ongoing studies that are evaluating these issues, but we still don't have a clear-cut answer whether or not a good anticoagulation in fact prevents dementia. And on the other hand, another important topic is whether or not a better rhythm control with ablation, whether if this approach may render these patients less likely to develop dementia and cognitive decline. And what we have earlier studies, case control studies, they have shown that suggested that catheter ablation patients who were successfully ablation, they have long-term rates of death, stroke, and dementia similar to patients without atrial fibrillation. And further, compared to patients with no atrial fibrillation, ablation patients had similar long-term rates of death, dementia, and stroke. So very promising data, although retrospective. However, early cerebral thromboembolic complications may also occur during atrial fibrillation ablation, and this may, on the other hand, impair cognitive function in these patients. And what we know is that the incidence of cerebral thromboembolic complications, they occur roughly about 0.5% in these patients, but most of these lesions, they are not permanent, they are transient, and the patients recover fully. And the most the important predictors of this complication is periprocedural bridging with heparin. So this is no longer used, so this likely will diminish the incidence of these embolic complications, although they still occur. And we know that these cerebral embolic complications, asymptomatic, mostly of them, they occur with all techniques, either cryoballoon ablation or irrigated radiofrequency, but they occur mostly with multi-electrode radiofrequency ablation, which is almost no longer used in the world. But it's also important to consider that many of these patients, they already have some kind of asymptomatic brain lesions before ablation, reinforcing the role of atrial fibrillation per se, creating silent brain lesions. Nevertheless, recent data coming from Korea have shown promising results in terms of the effects of atrial fibrillation improving cognitive function. And this was a prospective case control study, a small one, of course, 300 patients, mostly male, 60 years of age, 34% with persistent AF, and they applied the Montreal Cognitive Assessment Score after 3 months in 1 year after ablation. And note that as patients who were ablated as compared to the control group, they have an improvement in cognitive function 3 months after ablation that persisted after 1 year, and most reassuring that in this series, no postoperative cognitive dysfunction as 3 months was observed. This is a very important finding. And another interesting issue, the improvement was greater in patients who presented a previous cognitive impairment, showing that even patients who had a previous cognitive decline, they may benefit from a better rhythm control offered by catheter ablation. And more recently, this year has been recently published data also coming from Korea, now a very large cohort study, including almost 10,000 patients undergoing ablation and 17,000 patients with medical therapy. They were followed up as a median follow-up of 2 years, showing that as compared to medical treatment, ablation was associated with a lower risk of developing dementia. And these findings persisted even censoring these patients for stroke. The presence of a previous stroke did not impact data showing that both patients who had stroke or who did not have a previous stroke, they benefit from a better rhythm control and then develop less cognitive dysfunction as compared to patients who were treated medically, showing, reassuring that catheter ablation indeed is becoming a very promising technique and tool in order to offer some kind of benefit in terms of cognitive function for these patients. So what can we do while we wait for definite data on what we should do? What is recommended by the societies? We have this document which was published recently from major societies, including LAHRS, and we don't have strong recommendations, but it's very reasonable and acceptable to do what? Appropriate coagulation. This is very important. If you want to coagulate the patient, you must make best of your efforts to assure that these patients are adequately receiving the drugs, and if taking warfarin with a very good INR control. Also very important is general health measures that's used to decrease all cardiovascular risk factors. And finally, cognitive assessment should be performed in patients where there is suspicion of cognitive impairment. If you suspect that the patient is starting to get slow, the mental status is declining a little bit, it's important to perform a cognitive assessment. So in conclusion, atrial fibrillation is associated with cognitive decline and dementia independently of a history of a clinical stroke. Silent brain lesions are common and may explain at least part of the increased risk of cognitive decline. Anticoagulation is key, but it remains unproven whether it also reduces cognitive decline and dementia in AF patients. And finally, ablation may increase risk of mild cognitive dysfunction acutely due to cerebral embolism, but the long-term outcomes seem very favorable. So we believe that with good anticoagulation and the proper use of catheter ablation, we may offer a very good way of preventing cognitive decline in AF. Thank you once again for your attention.